Welcome to the Health Tech Heroes, where we talk to innovators who are rewriting the DNA of healthcare. Today, we are joined by Matt Hoff, Chief Executive Officer at Medication Solutions, the nation's leading provider of on-site and near-site pharmaceutical dispensing. After serving as an Army officer and Ranger instructor, Matt built a career across supply chain, merchandising, and pharmacy benefits, helping organizations improve access, logistics, and compliance at scale. At AS Medication Solutions, he has led a transformation from operations through to the CEO role with a mission to make it easier for patients to get medications they need, improve access, adherence, and outcomes while reducing cost barriers to care. Matt also serves on the board of directors of Healthcare Distribution Alliance, HDA, and is co-founding board member of LT Daniel Hyde Memorial Foundation, carrying forward his commitment to service and leadership beyond the four walls of any single company. In this episode, we will explore how his military and logistic background shapes the way he builds teams, scales pharmacy services, and rewrites the DNA of medication access in the US. Matt, welcome to Health Tech Heroes.
Thank you so much for having me.
So if you go back to West Point and your early Army years, is there a moment that really impacts how you lead today?
I think the biggest benefit you have going to West Point is it is a leadership school first and foremost. So from the minute you show up, you are being shown examples of leadership. It is very conscientious about making sure you're seeing both the good and the bad side of leadership, from real life experience, from academia to everything in between. You're getting exposed to leadership from the very beginning. And there's two sides of it. And I think one of the biggest things that you learn there is you have to be the right type of leader for the right type of situation and have the adaptability to know what's needed when and how to execute on both. And I'll give kind of a dichotomy that really stood out to me from the beginning. So the first summer is known as Beast Barracks. It's basically basic training at West Point. You go through and you spend a lot of time running around and doing push-ups and getting yelled at. And that's a very harsh type of leadership. It teaches you how to be tough, exacting, and standards, not from a receiving end as the subordinate, but from a leadership end. It teaches you how to have uncompromising standards. It teaches you that there's no friends when you're in charge, that you're the one who is upholding the standard, things like that. But at the same time, they make you memorize what they call plebe knowledge during this time. And one of the pieces of plebe knowledge that really stands out is Schofield's definition of discipline. And John Schofield is a very famous Civil War general from the Union side. And the opening stanza of it is, "The discipline which makes the soldiers of a free country reliable in battle is not to be gained by harsh or tyrannical treatment." So if you think about it, here you are, you're going through harsh and tyrannical treatment, and you're being forced to memorize something that says, this is not what makes you reliable in battle. And if you're in that leadership position when you're going through and the one who's doling out the harsh and tyrannical treatment, you're forcing people to recite something that says, the discipline which makes the soldiers of... The lesson that you can take from that is you're going to have wartime and peacetime in business just like you would with what I was getting trained to do then. And depending on the team, depending on the situation, depending on what needs to be done, but really depending on the team and its competencies, sometimes you have to have a more exacting, harsh standard to force raising the bar or force a behavior change or force a change management or force heads down getting done because you're fixing a problem. And other times you have to be more focused on developing a team that can independently on its own function at a high level. So when you think about building a high performing team, you have to have situations where you're coming in and really fixing a bad situation. And it's going to happen no matter how good everything you've done is. And there's times where you have to help a great team flourish and get the most out of it. And knowing when and how to switch, but keep consistency with your principles and keep consistency with core ethics and values. I think that's one of the most understated things that the military and the military academy teaches to young men.
So you said that there is examples of bad and good leadership in military. Is the bad leadership intentional, or there is really good example of bad leadership in military? Was it intentional or it just happens?
So I was at West Point from 2003 to 2007. And while we were there, it was not a question of if you were going to go to war. It was a question of when and how many times. And if you remember back 20 years ago, there were really bad examples of leadership being committed by folks in the U.S. Army at the time. And I think it'll be surprising to people, but whenever there was a bad news story that came out, we studied it. It would come up in classes, it would come up in formal military training, it would come up very recurring, and we would address and go over what happened, why it's bad, how it actually hurts the war effort. A lot of the really bad things happen, and I'm sure the folks on the ground thought they were doing the right thing or were acting out very reasonable given the circumstances, human emotions, but that loss of control overall was worse for the mission. And you would go through things like that, and we would study examples from history. So Band of Brothers, that movie series is obviously pretty influential, but we studied a lot of scenes of Captain Sobel or some of the other poor decisions that were made throughout that series. One of the worst things that ever happened in U.S. Army history was the My Lai massacre. And there was a case of a lieutenant who was either acting in an evil way or too cowardly to stand up to his commander and was derelicting his duty. We studied that. There was a commander above who was either negligent in controlling his subordinate or outright evil. We studied that. And at the same time, you had Hugh Thompson, who was the helicopter pilot who helped put an end to the massacre, who did the right thing and showed not only physical courage, but the more difficult moral courage to make sure that the right thing happened. So you learn probably more from the bad experiences than you do from the good. And anybody who's been in that circumstance or served in the military knows that there's bad and good, but making sure that you study that so you came out better. And that's really a lifelong learning thing is something that I learned there. And I'm glad that I've been able to keep.
Pat, let me ask you this question. This is like we are talking about high pressure situations, and you're getting trained, and the thought process is to figure out solutions, make the right decisions, morally right decisions in high pressure situation. How does that practically manifest with you because of your training, which is a little different perhaps from other leaders? What is that actionable trait that I can like immediately learn and put in play in my own life? There's something that you can elucidate.
You fall back to the level of your training. So what you practice is what you're going to execute, regardless of what situation you're in. So if we just stick with a business example, we have principles that we practice every day, which is first and foremost, there is a human being at the end of our services. There's a real patient who's putting a real drug in their mouth or whatever absorption method they go through, but there's a real patient at the end who's getting a real treatment, and that treatment is either going to make them better or it's going to make them worse. The absence of that treatment would make them worse. The wrong treatment would obviously make them worse. And so if you keep that guiding principle of we are always going to do what is ultimately the right thing for the patient, then you have a framework for if something bad does happen, what's going to guide your decision. And there may be a short-term feeling that you could get, maybe this one isn't as big of a deal, but we don't have to do something, or maybe we could cut this corner, or this is a tough situation and we have to choose between option A and option B. And option B does look enticing, but if option A is better for the patient, you always do what's right for the patient. And if you're going to take care of the patient, I am not in a purely B2C. I'm not generally interfacing directly with the patient as my customer. They're my patient from my pharmacy, but they're not my patient. I'm usually working with a partner who's the actual healthcare provider. If I'm doing the right thing for the patient, I will be inherently doing the right thing for my customer. And if I'm doing the right thing for the patient and the right thing for my customer, then I'm being a good partner. And if I'm being a good partner, then you can endure all things and we can become successful.
That's a really good mindset. I want to wrap this around is your moral compass. under high pressure should not change. It is your moral compass. And the second part, I think the way you ended, I really liked it, that you can endure through this. And I think that is the training part also that comes through. That look here, it might look harsh. The first point where you are going through a harsh and a tyrannical training, you will survive, you will endure it, and you will get through this. So what was the hardest part leaving army and redefining your purpose in a civilian life? I see you're flourishing, you're doing really well, but the transition itself would have been pretty hard, I think, philosophically too and operationally too. What was your hardest part? What is the biggest barrier you had to cross?
I remember my first day, and when I got out of the Army, I didn't know what I wanted to do with my life. I am a military history major. Like, that was my lifetime plan. And when I decided to transition, it was just basically, I want to go do something else. And I didn't really even know what the options were. But I will tell you, when I walked into my kind of office farm at Home Depot for the first day, and it's a wonderful place to work. But when I saw my cubicle for the first time, I think a piece of me died that I've never gotten back. I don't think I was ever designed to be that stationary. So I enjoyed that I can travel around and go to different customers and facilities. Routine is not my friend. I think the hardest part of transition that a lot of veterans go through and that I went through is you lose your identity. For a decade at that point, I was Matt. I was a infantryman in the Army. Everybody who knew me, even if they knew me from childhood or were family, were like, Matt, he's in the Army. Well, what happens when Matt's no longer in the Army? It was still, the war in Iraq was winding down, but Afghanistan was still hot and heavy. I lost some classmates pretty shortly after, including a pretty good friend within a year of me getting out of the military. And that was really challenging, really made me double think a lot of choices. And I had a lot of regret for decisions that I made at that time. So I think that loss of identity, that loss of tribe really is a driving factor for why a lot of veterans struggle. Veteran suicide is still a tremendous problem. I'm not sure if the number is still accurate, but a couple of years ago, there was a 22 a day campaign because 22 veterans from the global war on terrorism generation commit suicide daily. And losing your tribe is very difficult. If you look at previous wars in World War II and Korea, most people who were in that just entering the workforce or in that part in their career and family had fought. So they may not talk about it, but they knew, hey, if I'm sitting in my office, I may have been in Belgium, but the other guy down the street may have been in the Navy, but he was fighting in the South Pacific. There was a camaraderie, a culture, an understanding. Even with as divisive as the Vietnam War was, there still were a lot more veterans, and that generation was treated terribly. With our generation, it was the less than 0.5% of the population that served, and the military almost becomes its own caste and culture. Nowadays, you see a lot of folks who have sort of adopted that, wearing camouflage and tactical gear and dressing like the folks that were in the Army would have to dress in uniform, which is comical to me. But really, when I was at Home Depot, there was not another veteran that I knew of who had been in the same type of circumstance. Grad school, I did my MBA concurrently with my 3 years at Home Depot. I think there was one other veteran, and he served honorably, but he was in the Navy, hadn't deployed, so didn't have that real combat experience. And then my social life, there was one or two guys that were around, but kind of different experiences. And you lose that community. So you find yourself sort of on an isolated island. And that's a tough thing to do. I'll say I was able to make it through because I ran out. And I think a lot of veterans have that experience where you're going so fast in the military that it feels like getting off the highway. You're going 80 miles an hour, you take that exit ramp, and then it's 25-mile-an-hour school zone. I went into a full-time job that frankly I was not prepared for, not qualified to have. So I was struggling there, but worked hard and learned quick. I was doing a full-time evening MBA program, and I was competing in CrossFit. So I had really three things. I was too busy to notice how bad I was feeling. So I think that's an important thing, is you got to stay busy. The folks, especially the ones who get medically retired that don't have The one they don't have the need to go find another job because they're getting high percent disability, which they've absolutely earned. But they also have physical or mental restrictions that make it harder for them to jump right into the workforce or jump right into school or jump right into triathlons or woodworking or whatever the hobby could be. Man, I don't know how those folks make it through because you're going from prime of your life, running fast, so much going on to just kind of hitting a dead end and being confronted with your own mortality. So it is so much more difficult than people give it credit for. I think the VA and the military have done a better job. New programs like Skill Bridge, and there's a lot more resources that exist now than existed in 2012. And that's a great thing. I've done some webinars with HDA and some other things to help support whatever we can do to help veterans transition. And mentored a couple of younger lieutenants who are getting out, and younger captains too. So, find a friend, find a resource, find a mentor. It's not an easy process. You may not be the first person who's done it, but it's difficult for everyone.
There is a drastic mind shift here, and I think this also applies to just general industry right now because things are changing. So things will move from 80 miles to 25 miles, as I said, and we have to like really adjust immediately because there is like you can't do 80 miles in a school zone. You have to adjust. You have to play by the rules and make that mental reset. And sometimes you jump from 25 to 80 miles per hour and be ready for that too. I think it is a really great example of how you need to, it is going to be difficult and the current situation demands that 100%. So just going back into this before we talk a little bit more about AS medication, why is it important for you improving access to medications and what does it mean personally to you? So there should have been some backstory to this when you were younger that made you make these decisions because you ended up in Home Depot after military. You could have continued a career there. What made you come to healthcare? What is that the core values that align with you?
Home Depot's a wonderful company, and I could not have asked for a better first job out of the military. One thing that I felt that I was missing while I was there was something that was serving the greater good. In the military, you obviously have that. And part of the mission of West Point and something that I really took to heart was their mission is to develop very competent officers and people who have a lifetime of selfless service to the nation. And when I knew I was transitioning out of the military, that lifetime of selfless service to the nation was still an obligation that I felt that I owed to myself, to the academy, because everybody who goes there wins out a finite number of competitive spots. Whoever's spot that I wound up beating out, I needed to make sure I was still doing some good for the world. And while Home Depot is a great company and it helps people make their homes better, and that's very important, something around getting into healthcare really gave me that pride that I felt like I could go and at the end of the day feel like I did something that incrementally made the country better and made people's lives better. It's no secret that American healthcare is very expensive and we spend more per patient with worse results than most other modern economies. Part of that reason, and that I'm hoping to address, and I don't think I'm going to change the world of healthcare, but I think we can help change a small part of it, is medication adherence is very low. So only around 60% of prescriptions are picked up, and patients who stay consistent with them is very low. You look at something like the rise of superbugs and antibiotic resistant strains of bacteria, and that's exacerbated by the fact that patients don't finish their course of antibiotics when they get sick. They just take it till they feel better. And there's a lot of reasons for it, but I think one of the biggest ones is just simple access. If it was the 90s and you needed to get meat and produce, you went to the butcher shop and the greengrocer. Now you go to the supermarket. In the 90s, if you wanted to rent a movie, you had to go to Blockbuster. The only thing that I can really think of that still requires you to go to a third space is medication. You go to the doctor, and granted, there's a lot of mail order that gets shipped to home, and AS Meds does do that service, but you have to go to a pharmacy. And a pharmacy is generally a pretty bad experience. And I put no blame on the pharmacists for this. There's a lack of pharmacists, there's a lack of pharmacy techs. So that long wait and that overwork is due to a simple supply-demand economics. There's fewer pharmacists and fewer pharmacies and more patients getting more scripts. So you're in this death spiral, and then you have big chains that are either declaring bankruptcy or announcing major store closures. So the problem of patients getting their medication is getting worse and worse. And frankly, part of the reason American healthcare costs are going up is patients don't take their medication, they wind up in the hospital. Patients don't take care of chronic conditions, they wind up on more expensive to treat chronic conditions. If we're able to do more of a preventative approach or keep people adherent, keep them through their course of treatment for an antibiotic, keep them adherent on a lower dose of metformin instead of a very expensive brand medication, you're able to see those healthcare costs go down just through one simple thing, which is following the doctor's orders, right? We have the best, smartest doctors in the world. We have the most capable technology. We have all of these great things, and it's fantastic. But it doesn't do any good if the patients don't do what needs to happen, right? It's the joking example I give is if you went to an orthopedist and they said, you need knee surgery, and then they left the room and drove home, right? Like knowing what the problem is and knowing what the treatment is doesn't help you. They actually have to go in there with the scalpel and fix your knee. It's the same thing when you go see your primary care provider and they say, you need a statin. Well, it doesn't do any good and you won't get any better, or you at least won't stabilize if you're not taking that medication. So we think we have a radically simple solution, which is eliminate those barriers, that third space access, the social determinants of health that prevents somebody from going to get their prescription, put it right there front and center, and then you're going to get better outcomes. It's kind of a strange analogy, but I compare it to being an organ donor. In states where you have to opt into being an organ donor, there's a fairly small percentage of people who will opt in. In states where you have to opt out, it's a very small percentage of patients who actually will opt out. So states where you have to opt out have a higher percentage of organ donors. Well, for medication, if your doctor can hand it to you right there, and you can either pay cash or your employer's paying for it, or it runs through your insurance, just like it does at a pharmacy, you have an opt-out choice versus if they send it to a pharmacy, you have to opt in to getting in your car, driving to the pharmacy, waiting for 45 minutes, all of those things. So we're trying to make an opt-in into an opt-out.
That's a wonderful, really good analogy. And I love that orthopedic analogy too. It's like, hey, you need to fix your knee. Goodbye. Just making that immediately accessible and implementable makes so much more difference. A little bit more on AS Medication Solutions itself. If I don't know anything about AS medications, what exactly do you do? And can you also explain a little bit about the on-site and near-site dispensing as well, just for the context? And how does it impact a patient directly? What would be the patient journey with the AS medication versus without the AS medication?
So if you ask me that question in an elevator, I would say we're a medication access company. We provide a variety of solutions that make it easier for healthcare providers to make sure their patients are getting their medications. And what that means is we run full pharmacies. We do a unique on-site point of care medication dispensing solution. We run a mail order program, and we have a lot of, we'll call it ancillary and consultative services that help doctors and health systems figure out the right strategic approach to get better outcomes for their patients through medication adherence and medication savings. When you talk about the on-site care space, it's the best thing that very few people know about. I really truly believe that it's one of those things that once you experience it, you can never go back. But simply put, and every state has nuances and different laws, and we're working to try to bring states like Massachusetts, Texas, and New Jersey that have very restrictive laws that are out of line with the rest of the country, more in line with states like Tennessee, Indiana, California, Illinois, that have very great laws to help patients get medications. And it's not a red or blue thing. It's just it's not something people have really focused on. So we're trying to bring some awareness to it. But if you're able to get medication, and these are prepackaged medications, doctors and mid-levels do not want to and should not be playing pharmacist. Pharmacists go to school and get a doctor or pharmacy for a specific reason. We prepackage the medications. So if you're going to write a prescription or get a prescription for a 90-day supply of atorvastatin, that 90-day supply of atorvastatin comes prepackaged in a bottle. I am a manufacturer, and I have the same scrutiny and burden of proof that the right pill is in the right bottle that any other drug manufacturer has. We also provide a great software system that makes the dispensing of the medication as simple as checking out at a grocery store. So from a patient safety standpoint, it's virtually error-proof, and it gets the right med to the right patient quickly. Like I said, you can do a variety of payment methods, from using the PBM and adjudicating like a pharmacy would, to taking cash like a pharmacy would, or doing direct bill to an employer like some pharmacies do. So you have all of that flexibility, which gives an ability for practices to help patients save a significant amount of money on their drugs, not just the patient, but patients and employers. And that's a great thing that we're able to provide. But one of my clients has done a study, and they found that their patients in states where they are not dispensing, medication adherence is like around 65%. In states where they can dispense, medication adherence is over 98.5%. So think of that delta. That's almost a third of their patients who go from being non-adherent, not taking their medications, running a risk of getting sicker or needing a hospitalization, to going and becoming healthy and compliant. And that's just a fantastic thing. And like I said before, it's radically simple. You give somebody the ability to opt out, they're more likely to do it, versus you have it to rely on somebody's choice to opt in.
That is fascinating. Finally, do you have some kind of predictive analytics that these are the type of patients this particular physician is going to see and pre-package it, or how does this work? Or does the patient has to come back to the clinic to pick up the medication?
So the practice will store a inventory of medications, and it's the common things that they write for. So it's never going to be, okay, we saw Matt and he needs this, we're going to have him come back in 2 days to get the medication. That goes into that same opt-in versus opt-out problem.
Yeah.
They'll have a stock of those medications, and we help them determine based off of their prescribing patterns what they should carry. Granted, for urgent care, it's typically a similar formulary. For primary care, there are certain medications that they almost always carry. Every patient panel is a little bit different, but we have some really great pre-made formularies that are easy to go and very easy to start with. Because we have just a really great operation, we're able to provide guaranteed dating on our products. So even if it's a medication that you're not going to use but maybe one a month, we can still keep it on the shelf in a quantity that you'll dispense through, so that you have it available for that one a month patient that comes in. But the physicians have full autonomy and control over what they stock, how much of it they stock, and what they carry. And we help advise them, right? We're very against C2s in a doctor's office. We're very against, if you look at some markets, have wonky things that they'll dispense, and we always advise against those. And some of them we just refuse to carry. Like we refuse to carry oxycodone. We refuse to carry fentanyl. There's a place and time for those, and that place and time is with a fully trained pharmacist because of how dangerous those meds are. But for the very common medications, specifically or mostly generics, there's a great way for us to be able to keep these clinics in stock and get them the right product for the right patients.
And 90% of the coverage is going to be this general medications anyway. Just can you briefly define what is near-site dispensing as opposed to the on-site dispensing?
One of our biggest market lines is employer health. And in employer health, these wonderful companies that do a tremendous good for the world, which is provide primary care and occupational health for employers that give a medical home that they're sponsoring outside of what we'll call Gen Pop, whatever's in the local community. That dedicated system, if it's on site, it would be co-located with an employer. If it's near site, it may be at one or several locations around a metropolitan area, and multiple employers can access multiple clinics. So for example, if you were running a major manufacturer and you had over 250 employees, you could put a clinic right on site that has either a mid-level or an MD, and that is a medical home for your employees and their dependents. and they're going to get a much better level of care. They're going to have better access. They're going to have all these great things that allow them to really get taken care of in a much more robust way. If you're a smaller employer, or if you don't have one centralized campus, if you're sort of spread out throughout a geography, there could be near site that has 5 or 6 locations in your city that you can access along with other employers. And then these guys also have these great virtual care programs that allow even remote employees or traveling employees or after hour visits. And so you're able to tie all that together, and you sort of have this 360 coverage, right? You can get them wherever they are that's most convenient. You can get them even when they're not able to get into an office. And the bridge that we provide is, regardless of where they're going, we can provide that medication access. So it's just breaking down barriers and making healthcare easier and more accessible.
This is like literally physically meeting where the patients are, right? Yeah, we try to do that philosophically in all our business where the client is, but this is like literally you're meeting them where they are. Can you share one personal story, Matt, where this is the story that you spoke about at a Thanksgiving table and with your family, that, hey, this is why I do what I do at AS Medications?
We get a chance to go visit our sites and visit our clinics, and whether it's rural or urban or suburban, frequently we'll run into a story. So I'm going to amalgamate a few of them, but most of the patients will never know who I am. They won't know who AS Medications is. They may see our name on the bottle, but our medications are associated with our clients. And so we're kind of seen as the intel inside. They know there's a computer chip in the computer. They may not know who made it. But when we speak to the providers and their staff, we hear often, we had a patient who came in and he hasn't ever been able to get his medication because it's a 2-hour drive to the pharmacy, and he's a shift worker and it's never open when he can get there. So for the first time in his life, he's able to take the medication we tell him that he needs to take. We hear other ones that our patient would have had to choose between going back to work or getting their kids from school or getting their antibiotic. And a lot of times they couldn't even afford it in the first place. But because we were able to get it for them at a low price right here, that moral conundrum went away. And we'll hear Mrs. Smith was crying over that. And so a lot of our stories are secondhand, but like I said, we're not really the ones who are interfacing with patients every day. But when we get to hear from our providers that I was able to do my job better, I was able to take care of a patient better, while we may not be the ones who are getting the credit in the patient's mind, or they may not know what we did, the kudos really goes to the provider because they opted into doing dispensing. They opted into doing extra work. They opted into doing more to take better care of their patients. But getting to hear those stories of where it really came together, and they could see in somebody's eyes and somebody's actual outcome and how their day goes, that they made a difference, that's really great. We're an enabling company, and it's great to be able to see where you enable folks.
You use the word secondhand. We don't directly interact with patients. I think that's the core of health tech heroes, is that the opportunity cost is when you take away that layer, you can impact a lot more patients. So if it is direct hands-on, very high impact, few patients, but now it's like relatively really high impact, lot of patients. Anyhow, I want to jump into, I really want to go back to your leadership experience and ask what would be the biggest advice you will have for new entrepreneurs and leaders who are coming into this field, and especially from other fields which are not exactly healthcare. What is that single mindset that you need to bring to be successful in healthcare?
I think it's that the fundamentals are the same: hard work, open mind, and then just doing the right thing for your customer, for your patient, is always going to get you there. If you always think about what's best for the patient at the end of the day, you're going to get to a place where you're making a meaningful contribution to healthcare, and that'll make for a successful company. And I think that's just, if you have that guide star of patient care, and if you have that work ethic that you've developed, there's nothing that can stop you. Those are just the two biggest things.
And that is incredible. And I think in healthcare, margin for that is really, really low. And thank you very much for sharing that. As a final question for you, Matt, you have 90 seconds to share anything we might have missed or reiterate anything that you deem very important. The question is yours, the answer is yours, the stage is yours.
appreciate that. Well, first of all, thank you for having me. This is great. I love the opportunity to talk about the company and my favorite topic, which is myself. So always love having a chance to speak. But my biggest goal with these things is there's a better way and a better solution to get medications. Ask your doctor, start demanding of your folks that you can do in-office dispensing. And that'll make it so that this starts to become a commonplace practice. And we know the benefits are real. We know that the safety is there. And the more we can get the word out, the more patients are going to be able to benefit from this solution.
Thank you very much, Matt, for being here today. And I truly, truly appreciate the time. And there is so much more to explore. And perhaps we'll have another conversation in the near future. Thank you.
Thank you so much. I really appreciated the time.